I have known Randy for some time, and I actually expected you to finish the phrase, Bill has been amazingly successful despite his equally amazingly lack of talent, but you didn't do that, so I appreciate that. Randy and I met in Washington when we were both working on the Hill as health policy fellows, and in many respects Randy was my mentor then and introduced me to life in the Senate as a staffer. But the topic tonight is the impact of indoor air pollution on human health in the developing world. And my current position is I'm Associate Director at the National Institutes of Environmental Health Sciences. We're the only institute of NIH that is in its entirety separate from the Bethesda campus. So at times we are accused of being the country club of NIH, being down in RTP. But it's a beautiful setting, much like Eastern Tennessee, and it's a very nice lifestyle. About 2 years ago, the community, the environmental community, was brought into a process to develop a new strategic plan for NIEHS. And the effort here was to really develop new frontiers in environmental sciences and human health. And item number 4 here, that I'll blow up, was a goal to improve and expand community-linked research, and specifically making reference to developing a new program in global environmental health and to build capacity to pursue research in global environmental health. And at the time, and I came to NIEHS in the spring of 2006, the portfolio of our institute is and remains fairly small at about $5 to $10 million a year, because much of NIH is funded from investigator-initiated research. There are no real specific areas of priority. We do not have many federal or international partners in funding. And we have not made an effort to set priorities based on the global burden of disease. But the strategic plan in my assignment really was to try to rectify all of the above. And the strategic plan, one of the principles is that it is to be an integrative process and to understand complex human disease, and to do, because NIH is about research, training, and science. And so even though when you're in the developing world you need to consider how the research translates into service, this was our first step, and the focus was on integration. So as Randy said, I mean, this was not really my background. My background is as a pulmonary critical care physician. I've always had an active laboratory. I continue to do this. And this sort of outlines exactly what Randy said. But everything in my life changed as a result of this volunteer service. And I took a course correction. And in fact, this picture shows when landfall was made for Rita on August 29th. And that was my first visit to NIEHS up in RTP. And it was just coincidental that Katrina hit that day. And when I left NIEHS and went back to Cincinnati, it was a day the remnants of Katrina were over Cincinnati. It's as if God was sending me a message or something. I did call up Randy about a week later, and this was the hospital ship I served on. And I thought I was going to be here. I'm a critical care physician. I thought I was going to be in one of the most fabulous ICU settings anywhere. It just happens to be on a 1,000-bed hospital ship. But this is what I ended up doing. This is East Jackson County Center, where there are a lot of administrative services, but we were averaging 2,000 people in line every morning at 8 o'clock to be seen in clinic. And this was, I'd never set up a clinic before, and we sort of learned as we went along, but the temperatures were 105 degrees. People were incredibly patient, but saw renal transplant patients who had been without medication for 2 weeks. People were being helicoptered out to other centers. And then I went down to Waveland because the Red Cross asked us to set up a clinic in Waveland, and this is a baseball field in Waveland, Mississippi. And although New Orleans received a lot of the attention, Katrina did not directly hit New Orleans. The night before, it made a right turn, and that right turn took it right over the top of Waveland, where they had a 30 to 35-foot storm surge that went as far as a mile into Waveland. And so a whole strip of seaside homes, all over $1 million, were so wiped clean that it looked like a golf course. It was the most unbelievable setting. This is about actually a half a mile in from the shore, and this is one of the few pictures I took actually where there's not a Black Hawk helicopter in the background. There was always one circling in case somebody had to be taken to a hospital that was open. Got involved in things I'd never done as a physician. I'd never had to help somebody in this kind of setting with family members who had perished in the storm. So my experience in Katrina led me to change my career interests and to rethink why I had gone to NIEHS. And I negotiated the opportunity to lead this new effort in global environmental health. And the post-Katrina Gulf Coast, I thought, had a lot to do with global environmental health. Certainly there was broad devastation, and the principle of back to basics was necessary to solve problems. We didn't have, there was only one hospital open for about a 70-mile stretch, and that was in Pascagoula. The aftermath had huge environmental problems and health risks. And it was clear to me that at the center of all of this was destructions of homes and neighborhoods, which resulted in significant societal disruption and long-term impairment in solving problems and reducing risks. So as luck would have it, when I joined NIEHS on March 1st, the end of February, the city of New Orleans and others at NIH had decided that NIEHS should develop a study in post-Katrina New Orleans. And so on March 3rd, I flew to New Orleans, which I thought was somewhat ironic. This is a breaching of the levee in New Orleans, and as you know, although the storm was not a direct hit, the massive problems in New Orleans resulted from the flooding. And less well known is, unless you visit New Orleans and come up particularly the southern part of the Mississippi, as we did on our ship, this flooding brought environmental contaminants from all sorts of sources, including many of the oil refineries in the area. From an indoor air pollution problem, I think this was as fine an example of mold infestation as you'll ever see. And this has genuine impact on children. And we started a study called Head Off Environmental Asthma in Louisiana, a HEAL study. We visited first in March. We went back in April and May, put our protocol together in June and July, and had to go through 4 individual IRBs. But we got all of this accomplished and enrolled our first patient by the following February, which, at least in my personal experience, is a record. Again, considering the challenges of doing a study in New Orleans. Our partners were Tulane University, LSU, and the City of New Orleans Department of Health. It was basically a prospective randomized study that had 3 components. One was an epidemiologic study of asthma prevalence, detailed home environmental assessment and the living conditions. We were adopting our previously funded study of the inner-city asthma study, of which NIEHS was a co-funder, and put in a case management program and environmental intervention to see if we could improve the outcome of children with moderately severe asthma in New Orleans. And then finally, a gene environment study on these children to see if, in fact, through phenotype assessment and genotype assessment, that we could predict which children would be at highest risk. This shows you our first 135 children enrolled into this study, and the broad distribution. Unfortunately, the Mississippi River is shown on the slide, but it's not shown in much detail. I don't know if there's a pointer down here, but I can sort of point with my finger, I guess. But we have about half our children coming from areas that were flooded and about half not from areas that are flooded. This is one example, though, of anybody who's gone through a flood knows what this is like. This is one of the most miserable things that can happen to homes and to neighborhoods. And many of the areas of New Orleans have been essentially plowed under and remain today much as they were shortly after the storm. It's very, very sad. Although some of the financial areas of New Orleans have recovered, the re-entering population is about half of the original population, and many of the neighborhoods are not restored at all. So our linkage is to take New Orleans as one of our first models for the type of global environmental health programs that we want to develop. And it involved both developing a clinical intervention study as well as building capacity. But we wanted to proceed in a fairly cautious fashion. So this is the first conference that we put on looking at this issue of global environmental health. It was in San Francisco, where we invited 45 of the world's experts, about half and half international and domestic, trying to determine what are the key issues for NIEHS in global environmental health. We used the Pelston Conference format, which I was unfamiliar with, but someone in our organizing committee convinced us all to do this. And CTAC, which is really a global society focused on environmental toxicology, started this conference series back in Pelston, Michigan, 20 or 25 years ago. And it's very simple. You choose a specific topic, you have a small number of attendees, very few lectures, but once all the invitees are there, you inform them that there are going to be working groups that will be developing a consensus, and everybody's going to be writing. So it's really a 3-day writing workshop. It was held in San Francisco on Nob Hill, and nobody left the hotel for 3 days. But nonetheless, it was a very productive and launch for our program. Our purpose was to find 4 to 6 research topics that would include the following: an environmental exposure that led to a human disease, relevance to global health and the developing world. The exposure plausibly had to result in significant morbidity and mortality, and it would be a project that could be completed in 10 years. So we set this up in a life cycle of 3 working groups: maternal, infant, children, and adult. And we asked 5 key questions. And it really was trying to have these 3 independent groups face 5 critical questions that forced them to answer the questions in this document that each working group had to write. And so we ended up with a 35-page summary that we posted on our website that I think was really helped launch our institute in the right direction. But I want to show you sort of the top 6 areas that were recommended by the workshop. Some of this will be for NIEHS. Really, it's for everyone. And at the top of the list was biomass combustion and poor pregnancy and birth outcomes. Closely related, however, were acute respiratory infections, asthma, as a result of exposure to indoor and outdoor air pollution. Third was arsenic in drinking water and poor health outcomes, neurobehavioral deficits, and exposures to PCBs, pesticides, metals, susceptibility to infectious disease through environmentally mediated modulation of immune responses, and lung cancer in non-smokers in Asia. But 4 of these 6 are really related to indoor air pollution. And the type of indoor air pollution we're talking about is not exposure to moles. It's exposure to indoor smoke from burning of solid fuels. And to put this in some perspective, if you're interested in PM 2.5, where you're trying to figure out what's the right level, is it 10, 12, 7? In homes this is from Central America, you can easily achieve levels of 8,000 to 9,000. These are orders of magnitude above ambient levels that are considered tolerable by EPA and WHO. And as is noted, it is mothers of childbearing age and infants. And you can just imagine the mother cooking over the open fire with the infant breathing in this smoke. And keeping in mind, this same mother was, the child was likely affected in utero as well. And this whole emerging field of epigenetics and how gene expression is being changed in utero, this is exactly what we're talking about. This puts the child at lifelong risk for future disease. And as we are now learning, and I'll show you toward the end of the lecture, it puts women at lifelong risk for chronic lung disease. So biomass fuels, what we're really talking about is the burning of dung, and certainly in India and Bangladesh and other areas, this is the primary form. Elsewhere in the world, crop residues and wood. The types of biomass fuel emissions, we're talking things that you can easily measure, certainly carbon monoxide, but VOCs, the PAHs, and they vary depending on what's being burned. Dung is worse than crop residues, which is worse than wood. And really the level of 100 times is short. There are several examples where it's more than 1,000 times. And the target populations, women, pregnant women, infants and children, and the elderly if they're housebound, and individuals with chronic disease. Now I should add that when you talk about solid fuels, the one type of fuel that's added to this is coal. And the target country for coal is China, because it's arsenic-rich coal in China that is a major contributor to disease. And likely, I think, an emerging epidemic of lung cancer, particularly in non-smoking women in rural China. So the health effects linked to biomass fuels, first and foremost, increased stillbirths, premature births, infant mortality, and acute respiratory infections in children. To put this in some scale, 1.6 million children die under the age of 5 every year, with an 80% link to exposure to indoor air pollution. It's unbelievable. WHO says this is the 4th leading cause of morbidity and mortality in the developing world. And yet it is so underfunded to study. Obviously respiratory symptoms and the risks for COPD, asthma, cancer, TB, blood clots. In this slide I say less evidence, but there's already in 2007 very compelling evidence for the impact on COPD, which I will address. And the impact on lower birth weight. And as many of you know from a public health standpoint, the birth weight that you have as an infant is extremely predictive of your risk for a whole variety of diseases, several of which the findings are just coming out in recent years. So I want to introduce a couple studies. I realize we probably have a broad audience, but I want to introduce a little bit of science here. Kirk Smith has been the lead investigator in Guatemala on the rural Guatemala study. This is a study funded by NIEHS. And in this study reported in 2002, it was demonstrating that babies who were born to mothers using wood fuel weighed an average of 63 grams less than those born to mothers using gas or electricity. This has huge impact, public health impact. In Zimbabwe, a similar type of study, larger study, 3,500 childbirths, and classifying low pollution fuels as natural gas or electricity, medium pollution fuels as charcoal or kerosene, and high pollution fuels, wood, dung, or straw. But that babies born to mothers under these circumstances with high pollution fuels averaged 170 grams less than those born to mothers using low pollution fuels. So what are the health consequences associated with low birth weight? Well, it may not seem obvious to you, but so many of these things appear in late adolescence and adulthood, and means that for society and for the rest of their lives, they are at risk for premature death. Increased risk for hypertension, cardiovascular disease, obesity, higher insulin resistance, type 1 diabetes. You stop and think about that. Type 1 diabetes? What does birth weight have to do with type 1 diabetes? But I would argue a lot of this has to do with what you're born with. In fact, is you have growth of your organ systems, growth of stem cells, growth of other types of cells. But when you're limited at birth, you're likely having a lifelong limitation. And chronic lung disease. We have a lot of information on the effect of tobacco exposure during embryonic and childhood development. And this field is much more mature than the field of indoor air pollution. But we know from environmental tobacco smoke that there is a decrease in fetal lung growth and development and a decrease in maturation of lung function. And unfortunately, that translates to an increase in asthma severity, although not prevalence, bronchiolitis, viral infections, and non-atopic wheezing. And I am absolutely convinced what you're witnessing here is a model of epigenetics in action. So if you compare environmental tobacco smoke and indoor air pollution, are there mechanisms of disease risk associated with ETS that would be relevant to similar risks with IAP? And are the exposures of airborne toxicants greater? Well, we know they are by orders of magnitude. So I want to transition to a study of COPD in China. There are 320 million smokers in China. 67% of them are men, 4% in women. And some of this is changing. This is a 2003 study. I'll show you an updated study out of Guangzhou province in a slide or two. I'm trying to remember what the figure is. I think it's something like 25% of the world's smokers are now in China. It's an unbelievable number. And there's obviously a concern of this emerging epidemic of lung and cardiovascular disease. Well, in 2007, this year, or past year, the largest prevalence study was reported in China with regard to COPD, with 20,000 participants, only in China. This is reflecting a study population of 200,000. The overall prevalence of COPD, and this was extremely well documented, was 8.2%, 12% in men and 5% in women. And as you can see, 82% of the men who had COPD were smokers, 24% of the women. We might ask, why would 24% of the women who have COPD be smokers? Why not a higher percentage? And fewer than 10% of the subjects with COPD were in what's called gold classification 3 or 4, had ever received spirometry, the most simple test of airway obstruction. Well, in thorax, there was a companion study of this same area in Guangzhou, but it was comparing a rural area, Yunnan, with Liwang in China. And the overall prevalence was a little bit higher. But note that COPD in the rural area is 12% versus the urban area of 7.4%. And note that COPD in rural women was 7.2%. I mean, that's the level of COPD you see in men who are smokers versus urban women where that it was 2.5. And when they looked at indoor air pollution, they determined that rural versus urban exposure to coal was 10% versus 0.8%, and for biomass, 90% versus 0.3%. Really linking for the first time the exposures of biomass fuel combustion to COPD in women. So the current epidemiologic findings in developing countries link air pollution from solid fuels to acute lower respiratory infections in children, COPD from the recent studies, heart disease, lung cancer, asthma, tuberculosis. And of all of those, the ones that I would be interested in studying the most is asthma, because I would predict that asthma is not as common. There may be reasons that indoor air pollution does not affect asthma prevalence. And so what I'm faced with now is, if indoor air pollution becomes a focus of our institute, as a small institute, how are we going to look at a problem of such huge complexity? Well, first thing I would do is look for partnerships. And the lead agency in the federal government regarding indoor air pollution is the EPA. They assumed this leadership role as a result of a summit, the Johannesburg summit, in 2002. This is the one that followed Rio. Rio followed Kyoto. And what the Bush administration wanted out of the Johannesburg conference was not a treaty protocol. They wanted a product and products that in fact could be delivered within 5 to 10 years. And what came out of that and what was birthed was the Partnership for Clean Indoor Air. And the EPA has done a wonderful job. They've partnered with USAID. They have invested $2 to $3 million since 2003. And this partnership now consists of over 150 partners worldwide. Everything from institutes such as NIEHS that just joined, to the Shell Foundation, to a number of important funding institutes, NGOs, small and large, and community-based organizations, all focused on clean indoor air. Currently, NIEHS funds, as far as I can tell, the only indoor air pollution studies for all of NIH, and it represents less than 5% of our global environmental health budget. We have studies targeting the health effects on young mothers and infants, and we have a low birth weight cohort. But we are now developing partners. At NIH, we have the National Institute for Child Health and Human Development, NICHD, the Fogarty, which is the center that's focused on international, NIAID, we call the Allergy Institute, and NHLBI, heart-lung. The CDC, we've developed a partnership in the past year and have funded indoor air pollution studies through our Indo-US Joint Working Group. USAID to date has not yet signed on, although they've involved with 2 of our conferences. The State Department has not yet signed on, but they're interested. And the U.S. Global Earth Observation is a maybe at this point, because they believe they can track worldwide evidence of indoor air pollution through global positioning. So my challenge is, how does a small institute at NIH address big problems? And the solution has to be that we have to find partners. At NIH and at the federal government, we don't have flat budgets, despite what you might think. I was told that we have constrained budgets. So in an atmosphere of constrained budgets, the only way you can build new programs is to leverage your investment with other partners, and that's what we're trying to do. So what came out of our meeting in January were some specific recommendations and thoughts that we put on our website via the Federal Register, announced it in the Federal Register. It was put forth for public comments, received a lot of comments, and one of, I think, the best set of comments said, you know, you had a lot of good people at the table, but where were the foundations and the NGOs? And so we decided that as a follow-up, and that we closed our comments August 1st. So on September 28th, the last day of our fiscal year, in 8 weeks, we put together another international conference focused solely on foundations and NGOs. And the goals of the meeting were to introduce opportunities in global environmental health to a broader audience of foundations, NGOs, and other federal representatives, to determine the common barriers in global environmental health research and ways in which these barriers were or were not overcome through partnerships, and to develop working principles that can achieve sustainable partnerships in global environmental health research in the developing world. So this has become our partnership meeting, and it was another fascinating meeting. This time around, we had several institutes at NIH who were very active participants, some of the usual players. In addition, we had the EPA, CDC, again USGEO, and the State Department. But most interestingly, we had NGOs and foundations from around the world, all of which had a stake in the game, and for the most part had not been part of the overall federal government agenda, at least as far as NIH was concerned. And many of these are what we call the implementers. So those of us who do research think we affect change, but we really don't. These are the people who affect change, one of which was Randy's previous employer, Project Hope. But we had groups as different as Project Hope, the National Academy of Sciences, the Shell Foundation from Europe, Coca-Cola Corporation, but then smaller NGOs, Enzo Global from Germany, Water Partners International, Sierra Club, the Google Foundation. So it was a very interesting group. I apologize you can't see this. This is more of our agenda, but I wanted to point out that what we did in this day is there was a commercial message. Although I co-chaired this with Jacob Moss from EPA, it was really to put forth the NIEHS agenda, but then to get the response from the foundations and the NGOs, and really became more of a listening session. But it was a tremendous day, and we did have the president of the Shell Foundation fly in from Europe for this meeting, and he took this opportunity, because indoor air pollution became a theme of this, took the opportunity to announce that the Shell Foundation had just committed to funding 10 million stoves over the next 5 years to put into homes in the developing world. The largest prior commitment was 5,000. So this is certainly getting the attention of major organizations. And I want to use a quote. We never quite knew who to attribute to this. We had it recorded. But somebody stood up in the middle when we were having one of our vigorous discussions and said the world is intuitively weaving itself into collaborative networks, and those that do it better prosper. And it was really a direct, I think, it changed the course of the day, because we had a lot of people who were coming in from different perspectives. They had never worked with each other, and there was a little bit of yelling and screaming, not unlike January, but this really brought us together, this quote, and allowed us to have a single-day conference that has resulted in some tangible partnerships. So we did have a day of contention and shared perspectives because people had not been in the same room before. But NICHD, NIEHS, and CDC have formed new partnerships with some NGOs that they didn't know existed. There was a lot of expression of need for an expanded forum. And I think one of the highlights of the meeting is that there was a clearly stated consensus that there had to be some simplified electronic access to find out who are the potential partners throughout the world. And one of the most amazing things is when you look at academic health centers, schools of public health, medical schools, nursing schools, universities, whatever, NIH institutes, you could be working 30 miles from a university that's 30 miles from you in the United States and you'd never know about it. And so one of the things that we want to do is develop shortcuts that will make global environmental health transparent for everyone, and you can find out who your potential partners might be. And then we did another summary report from this workshop as well. So the interim outcomes from our program to date have been that indoor air pollution is a major contributor to increased morbidity and mortality in the developing world. It's tremendously underrepresented in our own portfolio, as well as of NIH and the federal government. That we signed on as a partner with EPA for the Partnership for Clean Indoor Air, and that we were committed to developing a Google map of the developing world for indoor air pollution, that we believe will result in new partnerships. Lessons learned: one, that NIH should understand its role, and that is we should focus on the quality of science, but probably more relevant to the global burden of disease. And that Eunice Maringo from Tanzania, who's the president of a community-based group that I invited, admonished us. And her group is Kiwakuki. It's a Swahili acronym that stands for Women of Kilimanjaro Fighting Against AIDS. And she was tall and sort of statuesque. And this was a very interactive group, but she spoke with a hushed voice, and the crowd just went silent. So for 20 minutes when she spoke, it was beautiful. But in the middle of it, she gently admonished us, and those of us at NIH, that researchers always seem to have enough money to identify the problem, but no money to solve the problem. And so one of the classic principles of community-based research is that if you're going to do research in the developing world, you need to link your research to the solution at the beginning, and you have to involve the community. And so this fits beautifully with our own strategic plan and what we want to do. I think the other thing that came out is that you shouldn't do partnerships top-down. I think the role of the government should be that we create a platform that allow the partnerships to develop organically, and that is our goal. And that we should be the catalyst. But we have to figure out the structure for how we can develop partnerships that will solve problems in global environmental health. So I came up with this idea, sort of borrowing the fog of war, that I look at this as the fog of global health. It's very obvious that there are far fewer partnerships that exist than required to leverage the investments and to augment impact on human health. And that the NIH and other government agencies have huge investments in research and service without methods to analyze our own portfolios. Now, NIH is trying to address this with OPASI. And OPASI is this new structure out of the Office of Director at NIH that's really trying to embed evaluation into the NIH portfolio. But it's $30 billion of thousands and thousands of grants and contracts. And we don't have the technology to understand what we're currently funding. So this is a major challenge. And I don't think it's something that's going to be solved in the next several years. I think also there's a fog because there is no strategic linkage of the investment by funders, not just NIH and the government, but by most funders, to the global burden of disease. There's a fog because foundations, scientists, NGOs, foreign universities, and community groups often compete with each other for limited funds. I mean, it surprises me, but it leads to the second point, is that some desire limited access of information for others because they're already competitive. It's sort of human nature. Those of us who have been funded by NIH for a quarter of a century, sort of what you live on. Those who get the information first, get the inside track, get funded. But the result of this for global environmental health is that despite our huge investment in the developing world, 1/2 the planet lives in poverty and/or environments that pose major health risks that account for the high global burden of disease. And it really can't go on this way. We have to change the system. So this is what we've started, the Environmental Health Map Project from NIEHS. And I should have put on here, even though we're funding it, we're bringing in folks from CDC, EPA, USAID, the other institutes at NIH, because we see this as a potential tool that anyone can use. And I apologize for how simple this is, but because I'm not IT, I asked for very simple slides. So I thought I'd just show you how we're setting this up. This is a typical Google map, and that's RTP. And the way we're going to do this is we're going to put it so that we'll have a mission statement of whatever the organization is, so that's the first thing you click on. Then you click on detail, and you can learn about what's happening at the site. But obviously, we're not doing this for North America. We're doing this for the rest of the world. And so this is Colombo, Sri Lanka. What we would like to have is, again, not have this be top-down. But if you're a community group in Colombo, Sri Lanka, if you're a university, if you're a foundation that has a program there, you self-populate this data. You put your data into this, and you make it available. And it'll be more of a Wikipedia model. The job of the government will be to make sure the data is pretty valid and accurate, but that it's available to everyone. And so Google makes this incredibly easy. You just put in the city, they'll show you the longitude, latitude. We will have very specific criteria about what will be included and the sorts of information so that it's measurable. But I think this will be one way that, like I was talking to Randy coming in from the airport. Randy was thinking about Belize, Honduras. Well, it would be wonderful if you could click on Belize and find out who else is there. Is EPA there? Is NIH there? Is Duke University there, or University of Cincinnati? And so the hope is that you'd be able to click on Sri Lanka, see who the potential participants already are there, and do you have a basis for a partnership? So the concept of this Google map is to directly address the issue of who is doing what and where. Plan to develop a simple database about activities in global health based on geographic location. The data, if we can develop it this way, would be self-populated by government agencies, foundations, NGOs, community groups. And that we would structure the maps, and that's why we're using freely available tools like Google, so that we could provide add-ons. I think it would be wonderful if universities on their own developed a Google map, because the first thing I would do is, once the map developed, we'd put it right on this. That's what Google allows you to do. The same token, if we do one on global environmental health, they could steal that, put it right on their map. It would permit strategic assessments for future opportunities, institutional partnerships. But I will bet you that if we develop the map, it'll permit access by the people who really like this sort of thing. That'll be students, trainees, faculty, and administrative leaders who have to make decisions now. And so if you're a student at ETSU and Randy tells you, well, we've got a program in Honduras, but what if you want to be in Zambia? Maybe you could click on Zambia and you'd find out that university has another student program. You go negotiate with Randy. Maybe Randy would say, wow, let's do that. But currently, it's almost impossible to have access to this type of information. So what I'm going to try to do is bring you full circle. I think many of the issues in global environmental health are about having a healthy home. It's true in New Orleans. I think you all understand this process. And it's true everywhere in the world. If you don't have a healthy home, chances are you're not going to have a healthy life. I think there are common features and lessons that we're learning in New Orleans that are applicable to global environmental health. First, that a healthy home is necessary for good health. It's basically an environmental justice issue. It's a human right to have a healthy home. Challenges to research and health studies include impairment or absent infrastructure. If you think it's tough to do a prospective randomized trial when everything is set out in front of you, try doing it in New Orleans, whether even today they don't have adequate health care. They don't have existing clinics. Charity Hospital remains closed. It's unbelievably difficult. And your investigators, they still have to go back to their homes. They have their homes and contracts. They have all their personal problems. This is exactly what happens in the developing world. You lay out all the plans, and it all falls apart in front of your eyes. Community engagement is essential. It's essential probably in all of our clinical research, but it's certainly essential in the developing world. And although the risk of the research is high, the impact is high. And I think that's the ultimate trade-off. So how do we examine these issues of indoor air pollution in the developing world in a broader context? Well, I always argue it's in the context of the trifecta of poverty, malnutrition, and overcrowding. These are confounding variables. I showed you lots of slides on indoor air pollution and low birth weight. But I'm sure we've got some public health people here who say, well, aren't they poor? Aren't they malnourished? Isn't that a confounding variable? And it surely is. But I want to also put this in one broader perspective, and that is the impact of air pollution on climate change. The highest levels of air pollutants recorded are associated with biomass fuel in rural regions of the developing world. But this can represent half of the worldwide problems associated with air pollutants. In India, it's estimated that 40% of the outdoor air pollution is caused by indoor air pollution. It's unbelievable scale problems. And India has the world's largest middle class, 400 million. That's the good news. They also have one of the world's largest impoverished populations. So my hope is countries like India and China are highly motivated to address this problem. They have excellent scientific infrastructures, they have investments that can be made, and they can lead the way in some of these areas. About a month or two ago, we had Margaret Chan, the Director General of WHO, who came in to talk about the health impact of climate change. And it's webcast, so you can go to this date, hear her lecture, and it's a stunning lecture. But I love the metaphor. I believe that climate change will ride across the landscape as the fifth horseman. It will increase the power of the four horsemen that rule over war, famine, pestilence, and death. So indoor air pollution is related to this process. We understand the correct interventions. We need more efficient stoves and heat technologies. We need to change fuel sources. We have to have culturally appropriate implementation plans working with the community. A stove that works in Guatemala does not work in rural India, trust me. And we need a measurable, we have a need for measurable health outcomes to evaluate these outcomes. You do not change policy by impassioned speeches. You need data. So I think we have taken our first steps for partnerships. In the U.S., we have our partnerships across federal agencies, which really have coalesced in the last 6 months. It has become incredibly promising. From our September meeting, for the first time, I think we're getting implementers engaged with NIH. We have to reach out to other foundations. Obviously, Gates, Clinton, Packard, Merck, others have been tremendously, Pfizer, have been tremendously supportive of NIH-funded investigations in the developing world. We need to augment that. And of course, our most important partners are the communities themselves. So I see this as a terrific tool, hopefully, to augment partnerships that include fine universities like ETSU. It allows you to get into the game. It gives you the same access to information that the Ivy League schools have. And I think it allows everybody to be far more creative at meeting the needs of your universities and your students, but at the same time doing good work in the developing world. And I want to leave you with my two last slides. One is Gretzky versus Goethe. And the key to research, it's always said about Wayne Gretzky, is I skate to where the puck is going to be. I'm telling you, there is an emerging epidemic of respiratory and cardiovascular disease out there, and I would bet my career that much of this is going to be related to indoor air pollution. And the second, and that is Goethe. And knowing is not enough, we must apply. Willing is not enough, we must do. So I'll leave this slide, and these are outstanding websites if you want to just get further information. The first two are WHO sites that have some outstanding recent publications on indoor air pollution. And if you haven't gone to WHO publications before, make certain you know how large the document is before you hit print. And the third one is the Partnership for Clean Indoor Air. Just go to Google and hit PCIA. The first thing that pops up is the EPA Partnership for Clean Indoor Air. It's wonderful. And then if we have students in the room, In next week's Chronicle for Higher Education, they're going to have an article focused on the Universities Allied for Essential Medicine. And this is a student-driven organization from 40 universities that are challenging their own universities as well as others to revise their patent policies on drugs discovered using university funds to make certain that those drug discoveries are made available to the developing world at extremely low cost. And so in this era of political change, and I think we're hearing from the youth that in fact they want to change the world, and this Chronicle article that's coming out next week is well worth reading. So thank you very much.
Questions for Dr. Murphy? The wealth around the world as a result of that consumption to alleviate huge misery in developing countries.
Yeah.
It seems like it gets back to a maldistribution of resources.
It does.
But if we would ratchet it down enough, we would solve both our problems. I just want to sort of think in terms of market forces, but think in terms of doing it differently than what we've done before. We talked about sustainability. We're not. If you look at the hockey puck for greenhouse gases and we look at our population, they're the same thing. Where are we headed? Houston, we have a problem. Not far from New Orleans, by the way.
Yeah. You said that correctly too. Very good, Tom. Oh, did you? Well, that's I think you're absolutely right. But you know, there's always a law of unintended consequences. First of all, the developing world is wealthier now than it has ever been. I mean, it's kind of amazing, but even in the poorest parts of the world, people are making more money than they once did. And countries like India, you know, with their $2,500 car, and India has unbelievable pollution problems. I mean, I like running. India is probably the only place on the planet, India and China. You run outdoors there, you just pay your dues. But as they become wealthier and they build highways and they mimic our lifestyle, added wealth in other parts of the world just add incredible complexity for climate change and other types of health risks. So I don't have an answer for what you're saying. I don't think it's going to be just addressing poverty. It may be more the maldistribution that you're talking about, and as we alluded to in private conversation, the tragedy of the commons is that we have expended a lot of the world's resources to get us where we are today, and yet we have no right or power to tell others not to expend resources to gain the level of wealth that we have done. And so one of the tragedies of the human race is it's very hard for us to stop what we do when it's in our self-interest to use these resources. And I just think from a health standpoint we need to pay attention to climate change. I don't know if any of our lifetimes and our children's and probably our grandchildren's lifetimes we're going to change the course of what's going to happen at this point. I think it just is a backdrop we need to understand. And I would, right up there with infection and then vector changes, I would put respiratory effects as the next greatest impact of climate change. Because just surface temperature changes are going to have an incredible exacerbating effect on both indoor and outdoor air pollution.
Bill, one of the solutions is new cooking technologies.
Yeah.
But in some ways, I find that a little frustrating. It sort of reminds me of impregnated mosquito nets for malaria. Both are very effective. Both have a time-limited solution. Is there anything out there that you see as a lasting investment that could be made to change that?
It's really I mean, I know Tony likes his economics. I mean, it gets right into economics. The president of Shell Foundation strongly cautioned us at our conference. So you have to think the implications of switching to any fuel that's going to compete with the oil industry, because that in the developing world means a huge government subsidy from that country. And so if you put kerosene out there and you say, well, we can get kerosene cheap. Well, kerosene is part of the oil market, and it means the price is going to go up as oil becomes more scarce. And you deal with issues of wood. I mean, the other side of wood as a fuel source, it leads to deforestation, which leads to some of your issues with climate change. And so I think in the interim, the solutions that are being provided are more efficient burning of whatever the source of the fuel is. Philips Corporation, the people who make the beautiful television screens, flat screens, they have built the most beautiful ventless stove that's a modification of the rocket stove used in Africa and other places. It looks like a cylinder, except it's stainless steel, wood handles. When you put wood underneath it, it can even be green wood. The EPA's tested this down at RTP. It turns on a little battery, and it converts what is an inefficient rocket stove into an incredibly efficient stove, so that an EPA has this beautiful system for assessing particulate matter release, CO release, sulfur dioxide release. And the problem is, right now they can mass produce it for $100. But that doesn't do much good if in Bangladesh the whole healthcare budget per capita is $25. But what's happening is NGOs, very clever companies are developing technologies that they believe they will be able to sell this technology to the impoverished people of this planet. And for me, it took a little while to get used to that notion. It was sort of like, what, somebody makes $1 a week and you're gonna be selling them something? But in point of fact, when you look at the data, when people purchase something that improves their lives, they will use it. If it's given to them, as would probably be my first impulse, it isn't incorporated into the cultural practice. And so these are sort of, and that's what the NGOs do. They use this market-driven tool. They work with foundations. They work with the new technologies. But the NGOs are often the ones who bring it to the villages and the areas that it's needed. But I really think right now the improved efficiencies is going to be the key. And trying to minimize consumption of wood and the deforestation problems, and the notion of having coal, arsenic-rich coal in China as a primary fuel source for homes is, I mean, China's going to have to address that, because they're going to have an epidemic of COPD, an epidemic of lung cancer, epidemic of cardiovascular disease. And as you know, cardiovascular disease is, lung cancer and cardiovascular disease are now two of the major killers in China. So these are sort of our collective problems. They're all related to the environment. And I think they're the perfect sorts of problems where universities that have expertise in rural health have a real role in helping solve these problems. And I think ETSU has all of that in front of it. And so I would certainly encourage Randy to think about this, and I hope that we have a Google map in some timely fashion that you will be able to use to find out where you might want to develop programs in the future.
So we have a few parting gifts for you. First of all,
They can pay for them.
Yeah, we can pay for that.
Yes,
As a federal employee, I not only cannot accept gifts, I can't even pay for gifts.
you can accept these,
Okay, all right. That's
I hope. First of all, present you this plaque of the status of honorary professor in the Department of Public Health here at ETSU. So
okay, well, thank you very much. Thank you.
We also have a couple of books for you that will help you remember your time here. We won't open them right now.
Okay.
The Encyclopedia of Appalachia.
Oh, wonderful. Wonderful.
Great reminiscence. And then a
Wonderful.
wonderful book of photographs from this region as
Okay,
well.
well, thank you.
And then the thing that we're most proud of is beginning of this year, we were trying to figure out what would be a great appropriate regional recognition for our leading voices experts, and the wife of one of our faculty members, who was a local artisan, came up with a brilliant idea that reflects the best of Appalachia, and she makes it herself, and she's even here tonight with you. But it's a quilt that reflects the
oh, how wonderful!
The beauty of the region. With on the back is all the local folk remedies, and then with thanks to Bill Martin.
How wonderful! Well, thank you so much.
Linda's out there as well.
Well, thank you. Thank you very much.